Hello, everyone. It's a pleasure to have time with you today here at this amazing International Myeloma Society meeting, the 20th, in fact, being held in Athens, Greece. I have the privilege of presenting today on options in frailer older patients in the context of early relapse, but focusing really on opportunities for patients and options specifically that lie outside of the classical bispecific and cellular therapy approaches that are gaining so much excitement in the field, recognizing that those approaches are obviously tremendously valuable to younger, fitter patients. But for frailer, elderly patients, these options may be less practical and less feasible, in fact. But above all, I think it's a matter of understanding that we need all the options in the management of this disease. And very importantly, as we think about multiple myeloma, to understand that it truly is a disease of subgroups. And in that context, we have to have our treatment options both available on the one hand, but on the other hand, have a rational approach to how we sequence and use them. So my session has really been looking at what do we do when we face lenalidomide and daratumumab refractory disease after first relapse. What options do we have? And we recognize that re-challenging with CD38-based therapy can be suboptimal in terms of responses and durability of response that we see. Say, for example, if you've already had daratumumab, a re-challenge with a daratumumab-based platform may be less ideal. Interestingly, you may be able to derive more benefit from an isatuximab-based approach in combination with other strategies. For the frailer patient, this obviously may be relevant if one thinks of isatuximab combined with pomalidomide, for example. But above all, you may also be thinking in terms of an opportunity such as elotuzumab and pomalidomide, which is a very reasonable combination, well tolerated, but we also recognize some of the limitations of that approach. So clearly, newer strategies are needed. And in that context, what I'm focusing on today is really what are they and what do they look like? And we're discussing, obviously, the opportunities from other small molecules such as selinexor, an XPO1 inhibitor, which is an oral agent combined with others in particular and dosed at a low dose in combination, can be really quite active. We're looking then at other opportunities like venetoclax and the translocation 1114 positive patients, where this oral agent combined with other strategies such as proteasome inhibition and in particular bortezomib, and in an appropriate patient in combination with carfilzomib, can be very active. So I think that there are important small molecule opportunities that are worth focusing on. The other thing I wanted to touch on, though, is importantly in Europe there is the availability of melflufen, which is a peptide drug conjugate, and this is very different in terms of its mechanism of action to traditional cytotoxics, and it works by a very targeted delivery system directly to the tumor cell, and so leaves behind it a lot of the side effects that we typically associate with conventional chemotherapy and indeed with high-dose chemotherapy. So with that in mind, melflufen in Europe is approved and used, typically with dexamethasone, and recent combination trials have shown really exciting promise there when combined not only with proteasome inhibitors like bortezomib, but also with daratumumab. And then as we think beyond those opportunities and look to where we're going in terms of new directions, I think it's important to recognize that we have a whole new space generated after both pomalidomide-based strategies and lenalidomide-based strategies have failed, and that lies with the so-called CELMoDs, which I like to think of as degraders. And these are highly targeted approaches which engage the cerebral E3 ligase complex and trigger a rapid degradation of both Ikaros and ALOS. These are key transcription factors that control not only plasma cell biology directly, but activate the immune system against it. And I think these are particularly promising because we've shown preclinically that they're able to overdrive pomalidomide and lenalidomide resistance. And then when we've taken this to the clinic, these agents have worked in patients in whom lenalidomide has failed them and in whom pomalidomide has failed them. And above all, what we're seeing now in triple-class refractory patients is promising activity from the most potent, arguably, of the CELMoDs, namely mezigdomide. I should mention there's been data at this meeting from iberdomide showing it to be very well tolerated and very active. And we also presented updates on our mezigdomide experience, showing that not only is it active even just as a monotherapy without dexamethasone, but especially combined with dexamethasone, as we published recently in the New England Journal a few weeks ago. When you combine it, and you do so in patients in whom all three major drug classes have failed them, you see a very solid response rate from just an oral agent of around 41%. And these responses appear durable and sustained. Now, what's very important also to note is we saw a response rate also in those patients who were BCMA exposed. In other words, they could have had prior belantamab mafodotin. They could have also had prior CAR T therapy and bispecific therapy. And in those group of patients, we were able to see promising activity, in fact, a response rate of 50%, no less, in those patients. Now, in terms of the durability of these responses, it's important to acknowledge that with the two drugs, of just mezigdomide and dexamethasone, the duration of response was around 7 to 8 months. Having said that, when you combine this particular platform with other drugs, like, for example, bortezomib or carfilzomib, or for that matter, a CD38 antibody, these responses are dramatically larger. They almost double in size, and at the same time, the durability is much longer. So we see great promise for these approaches in the future. And then finally, in terms of the other agents that we're discussing at my session today, one of the focuses is on antibody-drug conjugates, namely belantamab mafodotin. And this is a BCMA-targeted approach, which is not strictly a T-cell redirecting approach, which obviously is a bispecific, and certainly not a cellular therapy such as a CAR T, but it does target BCMA. Now, obviously, we've recognized the ocular toxicities associated with its use, but this has proven much more manageable. And as a result of bringing this toxicity down, we've been able to show you can administer this drug every 2 to 3 months in combination with other drugs, manage the ocular side effects actually remarkably well from a patient perspective, and then above all, engender a response when you combine it with other drugs. So we're very excited to have these other opportunities for our patients to complement the real revolution that we're seeing with the immunotherapies. For those younger and fitter patients, we're now seeing opportunities open for older, frailer patients, which we have to realize constitute, in fact, the majority of our patients with myeloma, recognizing that the median age of diagnosis of this disease is 70. So with that being said, it's been a very exciting meeting, and it's been a privilege to be part of the faculty here presenting on these exciting opportunities for our patients. Thank you very much.